So Paul, you going to be up at Worcester this weekend?
I think so.
Yeah.
Are you going to be there?
Yeah, Steve's going to be up there too.
I heard he's up there now, and he's
Wait.
going home Friday.
Well, we're going up Wednesday and coming back.
Where are you going to
Monday.
stay?
Oh, somebody's place.
But you got to let me know so I can get in touch with you so we can hook up because we'll be up there. I'll probably be there Friday.
Yeah.
So I have to work Thursday, and then we'll be there for the
No,
weekend.
it's one.
All right. So I sent Steve an email last night hoping that I could get him to consider staying an extra day, but I don't know.
Well, I think yeah.
No, I looked.
He's half retired, so he can pick these things up, right? You know? And have to worry about this kind of crap. Although it is work.
I'll describe it.
It was like seriously the cool.
Susan told me failed retirement.
So this, I'll pantomime out with that.
So no math. You don't know of any syndrome?
No, but they pick them up.
The other question I have is I have a guy who's deficient, again, HRCT2, and he says, is anybody trying to work on stimulating?
Well,
Just give it a
Road to go.
Well, but then it was
You guys have it really, like, in the bad old days, we never had food like we only had a water fountain.
turn on the
I should show you this one where they like give him the award.
Where are you right now?
He's up.
lights are on.
It was early this year. I'm all over it. Tomorrow we can go.
Oh, yeah.
It's like the people want to see it.
Oh, well, whatever's easier for you.
So where are you
No, I had my shoulder surgery last year, so I wasn't able to eat till March, but then it was going to go.
Are you working in that?
Colorado, January.
on the other half of the month when you're not.
So I was on the open yet.
And I never once in the last 4 years.
It's fun.
So you don't want to go there.
Wow. You're really getting
Well, you know what?
This point in my life,
good.
I don't need to deal with
Where did that?
Oh my gosh, I was like,
Well, the other thing is so close to everything else. You know, we go to breakfast. Well, when we were there, we usually do Vail and we do Copper, occasionally go up to Steamboat. It's a 2-hour drive. Of course, I got vehicle. Brother-in-law. Oh, yeah. So it's easy for us. Somebody like you, if you're going to a beach, you usually don't have wheels to take the shuttle.
So they have a snowmaker as soon as it's cold.
it's just like, this can stay.
We can drink all the way up to Asheville. That's about 3.5 hour drive from there.
He would have a centerpiece of the fireplace if he could, but I had
Going down there.
to, I had to radiolate somehow.
Butte one time. Jay's just was going to trust me. It's totally off.
So then.
Red eyes.
Next is Canada.
We're going to have to put it. Oh, you know, it's leaking through the time. What's the channel about that? It's not working. I'm taking all the Thursday. Well, probably it's Friday morning. It's not that there's much we can do but dry it out. I heard it's not that they ripped it out and dried it out. And had to put it in
Okay, Mike.
padding underneath.
Now, is it still the deal when you're in Canada, you call it your phone check a lot of
Your house or our house?
Like
No,
$1.
we didn't do that shit with me. We got the
Our test
one
is only
free.
like 10 cents.
text? I think we could text.
Well, the thing that's interesting is you get Sprint, and if we get an iPhone 6, calling and texting Canada for free. But you have to have an iPhone 6.
With Sprint. I have
Sprint.
AT&T.
I ain't gonna help you on yes.
You know, I should have told you that it's like 90 days to Tomasa it.
Well, they're gonna go for Whistler.
I don't know. I don't know what the. I don't know what the.
Well, not at all.
What's nice is you can get pre-checked with there.
I was a member for about 10 years, basically.
Yeah, those are really nice. So you can get TSA pre-approved things, and then you can skip it. So.
Yeah, since I was a kid around here.
I'll just be honest now. I mean, back in
Moving back. Oh, moving back. And then.
she and her significant guy just got a houseboat on like
You've got staged flights, so.
she works at
Do the pre-check on the first flight, not the second.
Yeah. Well, last time we went to Philadelphia, Sue got pre-checked, and I did it on the way there, and I got pre-checked on the way back. That helps a lot.
Brandon.
Yeah. But you know, I can't understand that. Every other, yeah, my son's okay, but if you gotta do this. 3.01. And Sue's like, let me have it every other day.
Well, you got a range in your picture. Oh, oh.
Well, we'll see.
Now, yeah. So Gary and Mike, we should plan a ski trip at Whistler, and I'll provide the lodging.
It's a great idea.
No, that'd be fun. I haven't been.
Yeah.
I haven't been to
Yeah,
Whistler in decades.
we can
Let me join the lobby.
sweep 6. We got 2 o'clock.
I'm going to.
We have to pick a time that everybody wants to go, and then maybe we'll make a CME course out of it. You know? We'll sit around drinking beer and talk about allergy and get credit for it.
Right off the trip.
I can't write it off because it won't cost me anything, so you can't write it off.
Yeah, it's one of those
We
where.
gotta get the diehards in the group and there.
Yeah, that and like I started this job and like
We should do it locally.
Sure.
When is Alphabet open? You do have a place there, don't you? Yeah. Coming in. Or is this Stevens there? No, I did a job.
Nick, I think I saw you on Thursday. Were you downtown in front of the medical office building? No, I was coming after I just was done as I had. I had my nose biopsy and then I had to have my teeth done. I saw you and I'm like, and then as soon as I'm like, because I heard your voice and I turned around and like. And then all of a sudden I saw you, and then you were gone. I think you were leaving, like you were driving away, type of thing. I saw you just getting in the car, and I'm like,
Oh, yes, I was picking up my partner who just had central surgery.
yeah. See, I was upstairs having my little cavity
Do you know
filled.
the Dahlia?
I go to
On the 12th floor?
in the 13th or 14th. I don't know.
Yeah, I was there.
I don't
Trying to
know.
figure out where am I going to, where am I going to push over so I can pick them up again.
Right, I know. It's very awkward.
It is.
I know. So I heard you say David like this, and then say Nick, and then all of a sudden it was just so chaotic. So I thought, but I heard you. I saw you. Oh, it's all right. I was sort of, I had all my bandages.
Arrived and you had somebody pick them up?
No, I just had
Drive yourself.
yeah, I know. No, I went to the dermatologist earlier and just learned about all this stuff. And now I'm like,
Giving up the procedure.
she just burned it off. It's just that. Then she took a couple baths. I'm good. Work wherever I'm at.
Isn't it funny that you're the expert? Right?
Well, funny.
Just some housekeeping things. There's no journal club the next 2 weeks.
don't show up. And Dr. Hogarth.
He's back a couple years ago. He talked to us about alpha-1 antitrypsin. He's from University of Chicago, and today he's talking about bronchial thermoplasty. So, welcome.
Hey, thanks for having me. Yeah, so it's nice to be back. I do two things in this world. I run a large clinic devoted to alpha-1 antitrypsin deficiency, and then I run the bronchoscopy program at the University of Chicago. So this is it. You guys will never see me again. I've told you everything I know. No, but thank you for the opportunity to come on out. I am going to talk about bronchial thermoplasty today, give you an update on obviously what's new and exciting, and also where we're still doing a lot of work. Make a plug for the fact that right now it's a ripe opportunity to conduct research in this area, as I'll show you. This is where the work is done. These are the people I work with. My other bronchoscopy partners, Dr. Murray, who is our nurse practitioner in our bronch suites, where we'll actually have 3 thermoplastic cases tomorrow. As far as conflict of interest, I do have an association with the folks who make the thermoplastic device. I've given lectures on the behalf of Boston Scientific, and I've taught people how to do this procedure at our suites, and so I've taught thermoplasty directly, the actual procedure. I have an unrestricted education grant that helps support our interventional fellowship at the University of Chicago, and I've been part of several of the research trials. The other conflict of interest is I'm close to Vancouver. I'm a diehard Blackhawks fan, and this was my day with the Stanley Cup, because in 2010, I was one of the team physicians for the Hawks, and so got to spend the day with the Cup. I've peaked. Life's been pretty much been downhill ever since then. When you're a diehard hockey fan, you get to be with the Cup. Really nothing kind of peaks after that. Nothing's better than that. So, all right, what are we going to do today? So I'm going to try to get an overview. I'm sure you're familiar with the procedure, but I want to give us an understanding of the role that it plays in asthma management, and at least where mentally we are positioning a procedure like this, or where you and I should be thinking about it and contemplating it. We'll go through the literature that supports the idea of thermoplasty and how it works and on who it works on. We'll also go through that literature discussion regarding some of the controversy of how optimal it is and how well it does work. We'll try to examine the science of what's changing after thermoplasty. Historically, it was just hey, the smooth muscle seems to get destroyed. And any time you hear simple statements like that, you know that they're obviously not true. And so we want to explore a little bit further what's actually happening at a cellular level after thermoplasty, and then talk about some other exciting things that are going on through here. So let's start with a case, and I think it's a case that many of us, and it's an abbreviated one, but I think it's one that we can all relate to through the scope of our practice. 34-year-old gentleman, severe persistent asthmatic, he's been on chronic oral steroids. He hasn't been able to actually get below 20 milligrams of prednisone for the last 3 years. He's on a high-dose inhaled steroid and a LABA, he's on leukotriene modifiers. His IgE is actually normal, and that had actually been measured even before he had been on high-dose prednisone, but reaffirmed normal. The ANC is negative, alpha-1 genotype is normal. I hadn't have available to me, I found later. He did have skin testing, again, on lower, it wasn't off of prednisone, but it was negative, and a RAS panel, for what that's worth, was also negative. And a CT scan that was done to look for other forms of lung disease or anything else that might influence this was negative, other than just showing the gas trapping on exhalation views that you'd expect on a chronic obstructive asthmatic. It's pretty unremarkable. And these are all the drugs he's on. I think we all can recognize those. So what else has been going on for this poor gentleman? So, the prednisone makes me do it. So let's talk about the non-monetary impact of severe asthma. This is just one gentleman, but we all know the literature on this. They talk about the fact that going anywhere is a nightmare. I mean, try going through the TSA with compressors, tubing, and vials of liquid. The spouse was worried about no matter where they go. The last time they were at a mall and somebody went by with that cheap, trashy perfume and was smothered in it, he ended up in the emergency room. They got to figure out how much they're going to take with them everywhere they go. And then my other favorite thing. At one point, he was on 18 different meds. He's got good insurance, so it's only a $20 copay or beyond. Yeah, but times 18, right? So we all have the thing we think of. I'm used to thinking, I've got good insurance, but I'm on a drug, or maybe 2. I can easily afford this. But even at $20 copay or more for 18 drugs, this is significant financial impact of this guy's level of severity of asthma. He's also frequently in the hospital and or the ERs, as we know, and no debate about it, his employer is not exactly pleased with him. Nor are any of his physicians, because every time he comes to see you, he brings more FMLA paperwork, right? Which is, I assume we all hate universally. So he comes to see us, we go through his history, we talk about why thermoplasty would be considered. He was referred to us directly for thermoplasty, understandably because everything else at the time hadn't provided any value. Immunotherapy had been attempted. It really wasn't clear what he was. A few things I think he was barely allergic to. It was a very, very odd phenotype of this patient. But he failed that. They tried. He's on oral steroids and yet still frequently in the hospital. He's been on meds. Those aren't really providing enough benefit other than a minor relief. Inhaled steroids, and of course, being on that much prednisone, he's now a diabetic. He's a young man with osteoporosis. Just absorb that for a second. And a 50-pound weight gain, and he's Cushingoid. And this is how much he was costing. So in a year and a half prior to doing thermoplasty, he spent 45 days in the hospital at $257,000. When we normalize that over 1 year, just to say what's this guy really cost, and how come nobody really wants to hire him, 33 days in the hospital at a significant cost of $177,000. And this argument falls in line with all the other stuff that you and I try to prescribe. When I try to get someone on omalizumab, for example, the insurance company says, "Whoa, that's expensive." I always like to show them this data and say, particularly for a patient like this, and say, well, what's more expensive? Your current plan. So we did thermoplasty, which is not cheap. Cost roughly at our hospital, because we overcharge, $50,000. Mostly that was the anesthesia costs. But he finished thermoplasty, flew through all 3 procedures. 17 months after thermoplasty, these are his quotes. "I can do normal things. Every time he ever has an attack, simple rescue inhaler takes care of it." He got 1 hospitalization in 2012. And in his defense, he had influenza. He's also off prednisone, he's lost 42 pounds. So when we look at his healthcare utilization, and this is obviously one anecdote, and we're going to expand off of this, but he's not costing so much anymore. So, I'm preaching to the choir here, but the unmet need for severe asthma. I guess in the end, it also depends on how you slice and dice it, depending on whose definitions, and it's anywhere from 5 to 20%. For me, it's always there's always that large cohort within your practice who even the staff know on a first-name basis or start to even recognize the number without caller ID because they're calling yet again, right? Oh, Bill's on the phone, And these are the people that remain symptomatic, obviously, despite standard of care. In fact, my little kind of mini canned speech to a patient who's been referred for thermoplasty, I tell them, I said, "You have asthma. This is the one thing that we're good at, right? This is a disease that we all know how to treat very well, and our meds are actually pretty good. And for a bulk of our patients, this is not a hard disease. In fact, a significant amount of patients you and I never even get to see because they're contained in primary care, probably appropriately because their level of disease is so mild. But this cream of the crop, and it's definitely not a tip of the iceberg, it's I think a large chunk of the iceberg, is got an unmet need. Because what's the solution? Chronic prednisone? What I do, I make all of my fellows take 5 days of prednisone so that they understand what it's like. Because anytime I kept running into them saying, "Well, there's just going to be 5 days of prednisone. What's so bad about that?" And I said, "Okay, you're going to take it now." I've been on prednisone. I can tell you I get a lot done when I'm on prednisone because I don't sleep. I become basically manic. I almost sanded the floors one time. And so the idea, what do you do for these folks? Now, obviously, there's a lot going on in this world for you and I. Some new drugs are coming down. There's a lot of research going on. So what else do we have? And let's at least kind of think about thermoplasty. So it's indicated, this is the bare bones, it's indicated for treatment of severe persistent asthma in people whose asthma is not well controlled with inhaled steroids and LABAs on high dose, right? So you get people referred to you that are on mid-range ICS LABAs and they say, "I want this procedure." My answer is no. You haven't failed medical management. You've not even had a workup for your asthma. As you know, I'm sure you guys have the same experience. Sometimes you're not even sure the patient has asthma. All right? So the procedure itself delivers thermal energy to the airways via the bronchoscope to reduce excess airway smooth muscle and try to limit its ability to constrict. So you don't cure asthma because nowhere on here does it say, "I massively destroy eosinophils and an inflammatory response and cytokines and go after the small airways." Not at all. You're still very much an asthmatic when we're done. But we very much reduce by smooth muscle. The idea is changing a lot of the symptomatology. That's what I'll show you, and I've got some other studies to back it up that we've done. It's 3 separate procedures. It's obviously, as stated, a very complementary therapy, not a replacement therapy. And in fact, that's actually, I had a patient referred to me 2 weeks ago, and I said, "Why do you want this?" Because they weren't on an inhaled steroid. They were just on omalizumab. And they said, "I want to get off omalizumab." And I said, "That's great, but that's not what thermoplasty is for, and there's no data that we're going to get you off of that." "Oh, then I don't want thermoplasty." And it was an unrealistic expectation of what the procedure. I said, maybe it'll work, you may get off of it, but I'm not going to stand here and promise you that. I have no data to support that. And obviously, it's an option. So, the idea, by reducing this airway smooth muscle in the larger airways, you'll reduce bronchoconstriction and asthma exacerbations, and hopefully improve quality of life. That's the concept here. And that's achieved through this simple device, this little disposable catheter. This silvery part right here is where the heat is applied, this 5 millimeter area, across in 4 different segments across the airways. You treat sequentially. So you hit an area, back up 5 millimeters, hit another area, back up 5 millimeters, hit another area. Attached to this generator that heats things up. And it heats things up to 65 degrees centigrade. Very, very hot. And we use radio frequency. And so the argument is, whoa, wait a minute, like that much energy, that much temperature inside the lung, that seems nuts. Here's the level of energy that's used for BT. And these are the increasing levels of energy and temperature that are used inside the heart. And so one of the, just up front, before this was, this was even being discussed as a concept, it was the initial like, oh dear God, there's no way we could do this inside the lungs. But meanwhile, our colleagues, on the inside the thorax are busy nuking, VT focuses and so forth, and destroying atrial fibrillation with much higher energy levels and much higher temperatures. That at least gave a rationale that we could explore this forward. So when I was a fellow, I didn't make the poster, but I got to work on this project with some of my colleagues at the University of Chicago and other places. And this was the first presentation in 2002 of the idea of bronchial thermoplasty could be. And one of the key things you'll see buried in here was that people became less sensitive to methacholine. And it was also proven to be, in this initial early experience, safe. This video, unfortunately, didn't get ported through, but what the video is supposed to show you, this is a dog model, so I'm gonna pantomime it for you. This one's going to get treated, and this one's not going to get treated. So if the video was playing, you'd see, obviously, us doing thermoplasty in the one area with the arrow, not doing thermoplasty in the other one, as it says, untreated. Now, then you come back, and methacholine is distilled right in the airway, just pushed right in. And the treated airway looks just like this. It doesn't constrict in any way, shape, or form, and that one constricts down to almost non-existent. Like, it's there technically, but you have a hard time actually seeing it. And it's a nice proof of concept of trying to decrease the bronchoconstrictiveness. It's pretty striking. Meanwhile, this was then back up. This is all the preclinical studies of what actually happens pathologically in a canine model. And I think what you can clearly see, significant amounts of smooth muscle, and then essentially the absence of smooth muscle. Now, this is great. There's some real issues, of course. Dogs don't have asthma, and so the model's got its problems to begin with. We'll talk about people later. So that should at least set the stage for the idea of clinical studies. There's been several relatively large, one small, I guess. This is relatively small. But studies published over the years to examine this inside humans. The original feasibility study, followed by the New England Journal published AIR trial. This was the first randomized trial, but not double-blinded. Then the research in severe asthma study, small study, but also trying to see how sick can you be, how sick is sick, or is there too sick. And then all of this laying the groundwork then for the pivotal study, the AIR2 trial, of 190 treated patients, many obviously control patients as well, going through thermoplasty, and this is what ultimately brought it to market. So just to get a sense from the first 3 trials of what kind of patient was treated, so you can look at the demographics, all, basically 39-year-old, female predominant, but male-female, relatively close to the split. If you look, though, across these 3 trials, these are the smaller ones, these are the baseline pre-bronchodilator FEV1s. So definitely some amount of fixed airway obstruction, some remodeling, etc. No, not somebody with 100% FEV1. You can see, obviously, the corresponding inhaled corticosteroid dose, as well as then the corresponding oral corticosteroid dose, at least in the recent trial. And the percentage of symptom-free days, which I think would reflect, we have patients like this. These are the people who, are being very much burdened by their disease state. And these trials, these are the kind of composite outcomes of these 3, smaller studies. Well tolerated in the feasibility, and the effect, actually, they follow these patients out now many years, and the effect has been persistent. But the AIR and the RESA trial were the ones that at least gave some thought process to what we might be actually approaching here. And it was improvement, obviously, in these validated AQ-LQ scores, reduction in exacerbations, rescue meds, and an improvement in symptom-free days. There was a trend towards oral steroid reduction, but not enough that anyone's all excited, but enough to make you think that in a severe patient, that maybe that we should be modifying our thinking to not say, well, we want to treat severe, but not very severe, or not extremely severe. I mean, recognizing those aren't medical terms. We'll come back to that. All of that, though, because of the improvement in the AQ-LQ, because this was safe and was tolerated, there were no deaths, there were no serious adverse events, there were some hospitalizations, but you are doing bronchoscopy on an asthmatic. What did you expect? That's what then allowed the setting for the AIR-2 trial, the pivotal study. This was a severe persistent population with high-dose ICS LAVAs, and the primary endpoint, as actually mandated through the FDA, was AQ-LQ. You wanted to show improvement in asthma quality of life. And as you know, this questionnaire, it's 32 questions in the AQ-LQ, and there are 4 domains, and these activity domains contain 5 patient-specific questions. And the whole idea here is to allow them, like a lot of these scoring systems, select 5 activities in which they're most limited, and that these are what they're going to be assessing. So it's not a question of, like, can you run? And the patient's like, well, I never run, but I bike, okay, well, let's focus on biking, and you go through the 7-point scale, and the idea is a composite of mean of the 32 responses. And so that's what was being used. And in a 2-to-1 randomization, so thermoplasty versus a sham bronchoscopy, they underwent thermoplasty and then had long-term follow-up. These were your inclusion criteria. So they wanted sick, but they didn't want extremely sick. So you'll notice you could not be on more than 10 milligrams of oral corticosteroids. You'd have 2 symptom days and a 4-week baseline. Your FEV1 did need to be greater than 60, though, and you couldn't be an albuterol abuser. If you look, about 190 people, it was the same age range, definitely still more female predominant, definitely Caucasian. The primary endpoint was the AQ-LQ. You'll notice 2 things here. So it's normalized to 0, so there's a large improvement. If you're not familiar with the AQ-LQ, you have to improve by 0.5 to be considered clinically significant. So it improved, obviously, almost by 1.4, and of course, over the time period, it ultimately went that direction. So that was very exciting. Of course, the sham arm went up as well, too, which was always distressing and hard to explain, but not that hard to explain, actually. I'll come back to that. Now, the key here, then, so you say to yourself, wait a minute, there's not a big difference between the 2. So we'll come back to that in like 2 more slides, but I will say one thing that's important. The AQ-LQ is a score that's used to assess my change, not my change comparatively. So it's sadly not the best tool to use as a comparator device between groups. It is a tool, though, that's great to use to understand someone's personal change in their asthma management. But still, there's clearly a sham effect from this study. Now, we'll see that in a second. What else did we see, though, besides the improvement in quality of life? And I'll explain here in a second. That improvement, that 1.4, is unprecedented in the amount that was seen. So, reduction in severe exacerbations and reduction in ER visits, both of which were statistically significant. And these were obviously very important. So besides saying my patient felt better, they were less likely to be a healthcare utilization consumer. They weren't going to the ER. They weren't having steroids and so forth. But let's conceptualize also the AQ-LQ by looking back at some other studies that have utilized this tool. So one of the original Advair studies compared, placebo to just an inhaled corticosteroid, in this case fluticasone, to then the fluticasone salmeterol. And both of them improved the AQ-LQ. Fluticasone by 0.55, that's clinically significant. And the combo by 1, but notice between the 2, if you try to use it as a tool saying which one's better than the other, 0.45, at least by AQ-LQ, not actually that interesting then. But I think we would all agree, in the right asthmatic, this is probably a better combo than this. Then you take a look at one of the omalizumab studies, and you'll notice again a sham effect. And obviously an omalizumab effect that is good, better than 0.5. We start here, the reason I moved this baseline up is here, obviously you had to be on this drug, so not, to be in this study. And you clearly got an effect from BT, and you clearly got an effect from sham. So how come in all of these, the AQ-LQ seems to be the same between the 2? Because again, the nature of how this tool works, is not from between comparator groups, but I think equally important is also, as you can clearly see even from this prior study, and I think you know this if you do any clinical trials, and having, actually, full disclosure, I'm a bad asthmatic myself. I've been in several studies, including this one, as a patient. I'm pretty darn, I was very, very, very adherent when I was in clinical trials. But when I was in clinical trials as a college student and as a medical student, prior to the clinical trial, I can tell you, I wasn't the most adherent of patients. But what about this other sham effect? We clearly know, obviously, intensely monitoring, you get better adherence. That is one effect. There's also this issue, because when you're looking at quality of life markers, there is a sense of heightened expectations. We see this in other trials where there's an increased placebo effect. This has potentially some explanation for this as well. I think the other thing to look at, though, is the clinical meaningfulness of AQLQ is dependent upon this within-patient change. And that within-patient score is 0.5 is what matters. So when you start to do a responder analysis, the people that actually improve and subtract out the ones who got worse, you start to see some interesting effects. Because when you look at this responder benefit, people that had a greater than 0.5 increase and divide out those that were, said they felt worse or felt nothing, you start to notice that roughly 80% of the thermoplasty patients actually notice the clinical effect that they wanted to achieve. And then when you start then and say, okay, well, I'm going to subtract out the 3 that said they got worse, okay, so that's 76, but I'm going to subtract out the 7 that say, the sham arm, you start to see a little bit more of a difference. It's still not perfect, and I think one of the big problems that we still have right now in thermoplasty is trying to figure out who this group is. Because what I tell all the patients up front is that based on the data, 20% of you aren't going to get any better from the procedure. Then we're going to do it. We're going to come out the other side exactly the same. And what I want to know is how to predict who that is, ideally. But it's not clear to me we're going to be able to. But then again, I think to myself, my experience in yours probably reflects this as well, with anti-IgE therapy. You're a candidate for it, and in some cases I started, and it feels like a miracle drug for some of these patients. Just dramatic improvement. And in other people I started, and it's like, and I'm expecting my anti-IL-5 therapies to be sort of the same effect. I think some people it's going to be a miracle, and other people it's going to be a, So I'd love to be able to tease out who gets better when and why. So when we tease out these numbers differently, it's still a sham effect that's there. It's always harder to explain, but still with a real effect for the patients. Now, what does a non-responder look like? So that's great, all these people responded. What's a non-responder look like? So one of our studies that we have ongoing, we take airway biopsies of thermoplasty patients pre and post. And in this one that we published, it's a case report, but this is lots of smooth muscle pre-thermoplasty, and in the same area, lots of smooth muscle post-thermoplasty. So it turns out smooth muscle response to heat is a bell-shaped curve. We're trying to actually figure out how to predict whose smooth muscle tolerates the temperature. Recently I was settled on 65 degrees centigrade. If you heat it up to 70, you'll definitely destroy all the smooth muscle, and a lot of epithelial layers, and some cartilage. But if you leave it at 65, in the animal studies, in about 80+% of the animals, you killed off the smooth muscle with no detrimental effect to any of the other airway structures. But there seems to just be a bell-shaped curve, if you will, in response to temperature. So sadly, there are people who, if we could dial it up to 70, for the temperature, we'd probably be able to help. Predicting why this lady can, go to 70, if you will, or why 65 doesn't touch her would have been helpful, but we don't have that yet. From a safety perspective, this is where I think one of the things, the concept here is fascinating to me. So we're a large bronchoscopy center. We do 1,700 bronchs a year now. And when I was first in my fellowship, the rule was you don't do bronchoscopy on asthmatics. You're not supposed to. It's dangerous. Well, it turns out that was one of those dogmas that had never been actually examined. It turns out it's not dangerous at all just to do bronchoscopy. And then the question was, well, what about this, though? It's one thing to go inside. It's another thing to actually poke and prod and nuke it. So the safety record here, the adverse events that were reported were all typically worsening of asthma within a week of having the procedure done. There were no major complications, the ones that you and I think would be most worried about, in particular this one. given the level of asthma that we're going after. And then ultimately the treatment effect. So you'll notice right here, more asthma, multiple symptoms during the treatment phase, but then a reduction afterwards. Hospitalization rates were higher post-thermoplasty. That's probably twofold. One, we did, make your asthma worse acutely. And two, as we were learning, I have to admit, my threshold to admit you during the study was a lot lower than it is now because I didn't know what I had just done to you, right? You were patient number 6 in the study. At the time there was a composite of about 70 patients that we knew that survived this. So we watched you a little bit more than we probably needed to. And that's not surprising. Most of the time, asthma aggravation. Few with atelectasis, as I tell the patients, I am going to give you a very glorified sunburn. You will get some amount of epithelial sloughing. It regenerates, but if you don't cough a lot, if you don't stay nebulized and moist, you will get a nice thick epithelial eosinophilic mucus plug and get some atelectasis. So that was the 1 year effect. Now the question is what happens after 1 year? Right? So, because it's one thing to do thermoplasty. You like that? I like that.
Skip that too fast.
Sorry, I'll put it back. Let me put it back. There you go. So each piece of bacon takes 9 minutes off your life. I should have died in 1732. So, that's some good looking bacon, isn't it? So, that's great. It seems to work in 1 year. You get those real effects. Does that mean every year I got to go back and do this because, it doesn't last? So, let's look at some data. So, the original Air1 trial. First question was, what happens 5 years later? Nobody died. There were no clinical complications reported, and pulmonary function was maintained. Okay, that's great. What about the recent? It was a smaller study. No deaths, no clinical complications, pulmonary function maintained. Okay, good. What about the Air 2 study? So some people lost the follow-up, but actually not a lot. So most were retained. So let's take a look, because the idea here was, well, we saw some clinical effects that lasted in 1 year. Were they sustained? So this was prior to thermoplasty, the severe exacerbation rate. 1 year post-BT, as reported. Here they are, year 2, 3, 4, and 5, and here's the average. So this was the primary endpoint, the durability of asthma control. So if your patient responds, at least from a severe exacerbation perspective, that reduction, not to 0, but that reduction is sustained. And that's sustained both by proportion of subjects and or via event rates. So this is not an issue of, you had some outliers, that you had a couple of people that drove your data. No. Now, if you put it into perspective of the sham effect, this was pre, here was the sham effect, here's the people that got BT, and then here's the average over the 5 years. So there was a sham effect, but a marked more change from the thermoplasty itself. Now what about ER visits? Reduction, sustained, both proportions and events. And again, putting into perspective of ER events prior to ER events 1 year on the sham, or 1 year thermoplasty and sustained. And then, respiratory adverse events, just overall. The real key to this data was to show that there was an increase. There was always this fear that you don't have bad asthma anymore. Now you have post-thermoplasty syndrome, right? That we were potentially creating a new disease. I don't cough anymore, but man, I wheeze all the time now, or vice versa, right? So the idea of looking at respiratory adverse events and or multiple symptom scores, which is here, you don't see any change here. So I didn't rob Peter to pay Paul here, proverbially. I didn't change symptomatology, nor did I create some new problem. And that was further answered. There was no change in hospitalizations in the sense of an increase. I'll come back to the slide in 1 second. That was further answered here. There was a theoretical concern that if I heat up your airways, how much bronchiectasis am I going to cause? Right? Turns out, basically none. Now, you'll forgive, I didn't design the study. This is the extent of the clinical phenotyping from an allergy perspective. Are you a seasonal rhinitis patient or not? So, it wasn't don't kill the messenger. But to the limits of that, the argument here, there was no difference in the average proportion of people that were experiencing exacerbations between those who reported seasonal allergies versus those who said, really don't seem to have a, quote, allergic phenotype. Limited as it is, what I will tell you is that it does make an argument that however you and I are clinically phenotyping you, kind of, eosinophilic, neutrophilic, allergic, non-allergic, whatever, the clinical effect of thermoplasty doesn't seem to be dependent upon that phenomenon. That you and I would still obviously come after those patients in our regular way, management-wise, inhaled steroids, LABAs, immunotherapy, etc., or no immunotherapy if they're obviously not in that category, but that the BT, one way or the other, plays out the same. Lung function seems to be sustained, pre and post, averaged out. And so ultimately this reduction seems to be sustained, and that was one of the things. This is actually what changed things dramatically for the insurance perspective. You know, we started getting this through insurance companies when they understood there was 5-year data. Now, I had showed you the reduction in respiratory adverse events, you know, and so forth in the Air 2, which is in green, and hospitalizations and ER visits and everything else. But what about that original AIR study or the RESA study where we knew that there was improvements in the lung function, sustainability of lung function? It turns out, same phenomenon of reduction in adverse events, reduction in hospitalizations and ER visits, no change. So this is unpublished data from the other smaller studies and their long-term follow-up. So at least the composite of sort of if you were going to do the kind of the equivalent of a meta-analysis of every clinical study that's been looked at long-term, you're seeing similar effects. It's a lot easier to start your day when you know it'll end with beer. So how do you select a patient? So patient selection obviously definitely is high here on this. This has been well studied in persistence and asthma. As you know, both you and I, our job is to actually make sure we have a right patient. But I mean, this goes without saying, right? I think half the time, not half, but there's not a trivial amount of patients that come to me for my severe asthma, and it's not. It's VCD. It's severe asthma because you don't take any meds and you live with a bunch of cats, and no one's taking care of your allergies. I mean, it's all the above, right? Or this has actually been one of my personal favorites. This is, you guys will be happy to hear this. So now in the last year, 4 people referred for severe asthma. It used to be under good control, and in the last couple of years it's getting worse, worse, and worse. Now it's always out of control. I'm always infected, yada, yada, yada. Nobody never checked IgG levels on them. And then they don't respond to pneumococcal titers for vaccinations. And you start them on IgG therapy, voila. My asthma goes back to just being asthma. And on an inhaled steroid, blah, 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 I'm good. And so common variable, very common, at least in this tip of the iceberg population. A lot of alpha-1 patients, a couple vasculitics, et cetera, et cetera, et cetera. So, and I stress, and you guys know this as well, but I tell them over and over, I haven't cured a single asthmatic yet. And we set expectations very realistically. We want them to understand that for some people, nothing's going to happen. And for other people, the exacerbation rate's reduced, not zero. You will still sometime be on prednisone. You're definitely going to still be on inhalers. And in our clinic, I tell them, you're going right back to whoever referred you. Like, I'm not becoming your doctor. I'm here to do your procedure. You have a good doctor. That's who referred you. You're going right back, because you're still going to need them. This isn't you jettisoning doctors because you got the miracle procedure. So we're very upfront about that because I honestly, it's kind of like the transplant discussion. You want to weed out the people that aren't committed to actually managing their asthma. Obviously, we deal with who can you not do this on, or who should you do it on. As we talked about, it hasn't been tested below age 18. We had a 17-year-old who was a perfect candidate for it, and her insurance company refused to pay for it. So we did it on her 18th birthday. And she's done fantastic ever since. Literally, that's how she celebrated her birthday. That's really about it. So where does this belong? I think no great shock. This is where we should obviously consider using thermoplasty. Step 5, step 6 type patient, obviously. You're not on max dose inhaled corticosteroids and LABA therapy, etc. Then we should be stepping you up. But it's in this group that you and I, at least based off the 2007 guidelines, is where we would position thermoplasty mentally. It's been endorsed, obviously, as a procedure, so this is not, my little shtick or with my conflict of interest, Boston Scientific's little shtick, multiple different organizations that, some of us are members of, etc., have said that this is a good procedure in the right type of patient. So, our protocol at our own institution, this is what we do. And obviously, if it hasn't been done, and sometimes the patient, rightfully so, has come with a correct workup. We spend a lot of time on adherence, actually proving that you're taking it, how you're taking it. Add exhale nitric oxides to it. We've got a paper that will be coming out shortly. It doesn't seem we alter this at all, exhale nitric oxides, which probably shouldn't be a big surprise. But we obviously go after key alternative diagnoses. This is just you can get this, I think, off of up to date. Who shouldn't be treated? Someone who can't tolerate a big, massive amount of RF, so people with internal devices, people who can't be bronched, and people who've already had thermoplasty. That's it. Everything okay? Yes. Come in and have a drink. No. Come in and have a drink. So, does it actually make a difference pathologically? Dogs don't have asthma, but people do. So this is from one of our papers that we published discussing the role of bronchoscopy and biopsies for thermoplasty. And you'll notice here, especially here if you look at the trichrome stain, looking at muscle, really, really, really thick, smooth muscle, with also lots and lots of eosinophils. And then you'll notice here, really, really no smooth muscle, with lots and lots of eosinophils. This is still very eosinophilic asthmatic, who still very much needs to be on his meds. But now, not having much in the way of exacerbations. Actually, this particular patient hasn't been on steroids now in 4 years. I don't have data on it for you, but we're working on this paper as well. There does appear to be a reduction in glandular tissue, for what that's worth. It's not like we're measuring sputum and measuring like volume or whatnot, but there seems to be a reduction in glandular tissue. But then the real question is, when we opened our thermoplasty shop, said, all right, we're doing thermoplasty. We literally got the device 1 week after FDA approval. And everybody referred to us every one of their disasters, right? This guy's only been intubated 6 times. Can you do thermoplasty on him? This guy's FEV1's 40% of predicted. Can he get thermoplasty? This guy hasn't been off 30 milligrams of prednisone in a decade, etc., right? We got everyone's cast-offs. None of these people have been studied, right? None of them qualified for a single trial. But our predicament and our sort of mantra was, okay, but there's nothing else for these people. I mean, they're being literally killed by their disease. So can you do this on, quote, sick, quote, quote, sick, very sick, whatever you want to, very severe asthma, extremely severe asthma, pick an adjective, I don't care. So we published our experience, at least from a safety perspective. 8 severely obstructed patients with a mean FEV1 of 51%, and number of hospitalizations in the year prior, basically right around 3. So, a very ill patient population. Some of these people had histories of pneumothoraces and pneumomediastinum, they'd been intubated, etc. Nobody had unexpected severe adverse events. Among the 8 people who had followed for at least 15 weeks, there was no decline in FEV1. A couple of them spent the night in the hospital afterwards as a precaution because we were scared, but they themselves, the patient, did fine. So at least it was an argument, granted, limited as it is, of 8 whole patients that says you can do this. We've got a clinical follow-up paper that's under review, the average of 2.8-year follow-up of these patients. It's under review, but what I can tell you, to the limits of embargoes and whatnot, is that there's been an improvement in their asthma quality of life in 6 of the patients. 1 of them is about the same, and 1 says, I think I'm worse. But it's not clear she's worse from thermoplasty other than just she's never got off any more prednisone. She's now got worsening sleep apnea. She's got diabetes. So we're not sure. There's confounders. Who's this Rorschach guy, and why does he paint so many pictures of my parents fighting? So we'll transition over to what else might be going on. So when I said this is an area that's ripe for investigation, our group, we've been able to be steadily publishing in this area because there's not a lot of work going into it. And so it's a ripe opportunity for those of you looking for projects. What happens, there's always been this debate of, okay, does thermoplasty just go in and quite literally destroy the muscle? And what is the smooth muscle anyway? Just this passive, like it's just there and it's annoying, so that's why getting rid of it doesn't matter. And does it really have any effect on airway inflammation? So, how about an evaluation of airway inflammation after bronchial thermoplasty for severe asthma? This has been EPUB'd in the Annals of American Thoracic Society one of our postdocs, Darcy Denner, did the work behind this. So endobronchial biopsies and lavage samples from 11 patients with severe asthma were collected from the same area prior to and then at 3 and 6 weeks post their initial thermoplasty. And we looked at cell proportions and cytokine concentrations in the lavage and the presence of alpha smooth muscle actin in the biopsies. What did we see? So actin expression was decreased in these biopsies of 7 of the 11 subjects. That probably comes as no great surprise. You're trying to destroy muscle. So you at least try to, and pathologically, there was muscle reduction. But not in everybody. But in the lavage fluid, TGF-beta1, anti-CCL5 were substantially decreased in post-thermoplasty in all of the patients. And then the cytokine tumor necrosis factor-related apoptosis, TRAIL, hence the acronym, which induces apoptosis in lots of cell types, was increased in concentration. And that might be both an injury-related phenomenon, potentially, but it's also fascinating, and this has never been described, about what's happening in there, especially when we start to look at TGF-beta1 and the RANTES, on whether or not we're actually seeing an effect on inflammation because of what's been happening with the smooth muscle. Because it turns out, so I don't have a slide on this, but there's a nice review coming out shortly on an update on thermoplasty. There's a couple other groups that have been looking at how much the smooth muscle actively participates in airway inflammation. That it's not just the guy receiving the signal and causing, constriction, that it actually is involved in inflammatory cell recruitment and part of the inflammatory process. And it's all preliminary data and so forth. But I think it's exciting because there's an argument at least starting to be made, and we're hoping to build upon it, and others are definitively building on that, we're collaborating with, that there's a little bit more going on from an inflammatory perspective and within the airways after thermoplasty, not just I nuked the muscle. And with that, I'll say go Hawks, and see if it turns out we were both in the same placebo group. See if there's any questions. I always try to finish early because Lord knows when things go late, it just ruins your day. Sir.
I have two questions. One is, you said you can't increase the power level without getting in trouble, but how about repeating the number of procedures? Is there a limit to doing 3 or 4 or 5 of these?
What a great question. It's not been done. We don't know. We don't know if you don't respond, what if I go back and do you again, right? It hasn't been explored clinically, and I know the insurance companies aren't going to cover it. And the issue is raising the temperature obviously is not possible both engineering-wise in the device, but also concerned because we saw, we destroy the muscle, but then we get real damage to the epithelial layers. When I go back, and one of the things I forgot to point out, you'll notice, the epithelial layers essentially the same. It's regenerating from post thermoplasty, but there's not some effect there. It grows back. It's it's skin, quote quote. So it's like a sunburn, but it grows back. I'd love to be able to contemplate doing thermoplasty again on some of these patients. Now it is interesting though, but I didn't mention, and I need to dig up the paper and put the slide in. There's always been this debate about what else is thermoplasty doing, not just the inflammatory side of things, but also are you destroying innervation? So are you denervating all this? And maybe that's partly why you're also seeing an effect on smooth muscle. Because there's actually one small paper that's a French group that's doing airway biopsies, and they were able to demonstrate on a good responder, the right lower lobe, no smooth muscle. But we don't do the middle lobe in thermoplasty. The middle lobe is left untouched. I'll explain why in a second. And they biopsied the middle lobe, and the smooth muscle is gone. How's that possible? And so unless there's a more system-wide effect. And by the way, the reason we don't do the right middle lobe, the right middle lobe, because it's relatively narrowed and relatively long, and very predisposed to developing bronchiectasis. When nobody knew what the long-term effect of thermoplasty was going to be, all the clinical studies avoided the right middle lobe. Because again, as I was predicting, as we sat around and said, what's going to go wrong here? Well, bronchiectasis is one of the things that could probably go wrong. Turned out no. And it was like, well, what part of the lung loves to develop bronchiectasis? Let's face it, the right middle lobe's sole purpose in life is to develop bronchiectasis, right? And so it was not touched. You had a second question.
Second is, can you use a high-risk CT to pre-screen people to look at the airway muscle thickness and see who's a good candidate versus bad?
What a great question. In fact, that's a question I've been posing to Boston Scientific for 4 years, and their medical board refuses to give me the CAT scans pre and post thermoplasty from the Air 2 trial. I've been assured the answer is no, but what I would like to do is look at it myself, and especially using some of the quantitative softwares like Vita and other ones to actually look and see if there's a signal. Because we've done thermoplasty on a patient and had CTs pre and post and showed a marked increase in airway diameters and number of airways visible on CT scan. I don't know if that means anything, but it's interesting to say after thermoplasty, full inspiratory CT, high res, whole new areas of airways were actually able to be seen on CT. I don't know if that means more things are open, N of 1, but boy, you could explore it, right? And it's frustrating to me because we've got 190 patients who we know who ought to get CTs pre and post and who had thermoplasty done, and we know whether you responded or not. And I can just tell you, this is the one trouble with large multi-centered studies with lots of people who have lots of egos. I wanted the data, the medical science people have offered it to me, and then it gets squashed by the research committee for whatever reason. The politics of studies, right? People wonder why everyone does single-centered studies. It's just so you don't have to deal with other people. Sir.
I'm trying to understand the sham effect a little bit better.
Yeah.
And we know that anytime you do any intervention, there's a group of people, just by virtue of being observed, the Hawthorne effect,
correct,
are going to do better.
Yes.
But they're not going to have the physiologic changes that you showed in your long-term studies.
Yeah.
So in the follow-up of those folks, what happens to them? Does their improvement persist, or do they get worse? Are they followed this closely? Are they observed and monitored as closely?
This group right here. So so here's the problem. So this group, so they had this reduction in ER visits.
Right.
What happens at year 2, right, for this folks? And here was the BT group, sustained. At the end of the 1 year, the sham group, once it's basically got FDA approved, they got transitioned over into thermoplasty. And the argument was because it's a severe group, you couldn't ethically hold off, and so we don't have a long-term control group.
Okay.
And it's definitely a weakness because you can see this. You're right. I mean, did this sham decrease in ER visits go back up at year 2? Did it go down even lower? It just took more time.
Right.
We don't know. To the limits of obviously how one can do this statistically, what I guess we could say is we do know that if we don't do anything to you, and your own clinical experience tells you how your asthmatic pathways are. So to the limits of historical controls, the improvement that you see, it seems to be there now. Maybe this, like here, ER visits. I could make an argument if someone said, well, tell me why you think sham had a decline in ER visits. Well, if I can call a study coordinator instead of having to go to the emergency room, and the study coordinator handles my stuff over the phone, maybe that's why. I still was sick. I still was told take some more albuterol, or here's an antibiotic, or whatever. But I didn't go to the ER. Maybe. What I don't have is how many coordinators got called in the middle of the night, sort of thing. Or how many fellows took a phone call, or whatever. Yeah.
You talked about the effects of looking at inflammation. Has there been any effects in terms of development of like an abnormal fibrosis or scar tissue, because you are giving them a pretty big sunburn?
Yeah. What a great question. So our post-biopsy study, the furthest out we've got is a 6-month post-biopsy, and there is some fibrous tissue there, but there are no fibroblastic foci. So there's not a thought that it's and the amount of fibrous tissue that's there at the 1 6-month patient is the same amount that we're seeing in someone who's at the 6-week mark. So the argument of that time period. Now, what the study that I've been trying to get funded is go to my people, some of whom are now 5 years out, and bronch them. And take airway biopsies 5 years later. What are we seeing? Clearly I have zero clinical indication to bronch these people, so if I can't do it inside the confines of a research setting, it's not going to happen. The problem is that the budget on a bronchoscopy study is, expensive because you've got to actually pay for the bronch, and it's not just recruit someone to come to clinic and, take an inhaler, get an injection. And so we've had trouble getting it funded, needless to say. Yeah.
Has there been any work done in phenotyping the type of patients that should go to this? Yeah. With the more and more amount of biologics and everything else coming out, this is going to be very expensive. And it'd be nice to not jump around.
I agree, right? No, I mean, because all the biologic therapies are not going to be cheap either, right? And which biologic? You know, when there's an IL-5, IL-13, and IgE, and anything else coming down, which one do you start and when? Or do you just go to this? Or what's that?
This will be cheaper than any of those.
Well, that's true because this is once and done, right? I mean, you're absolutely right. I mean, that's the argument when I've gone to peer review, and they're like, "Well, we're going to cover omalizumab," and I said, "Well, the patient's already tried that. It didn't work for this particular patient. And how much is that costing you every year? Versus one and done." Now, I've had patients on omalizumab had significant improvement. Their symptom scores dropped, but not enough yet. I mean, they were still sick enough, that we proceeded on with this, and they've not come off of it either. For a lot of these asthmatics, I tell them it's a game of inches, right? And we're chipping away here for some of these people. There's a lot trying to figure out, right now, a lot of our work in our center is trying to figure it out from the biopsy samples with a clear and obvious major problem here. It requires me to bronch you first before I proceed down towards, doing the procedure. Now, I could make a counter argument and say airway biopsies and the ability to see what kind of cells are in there may actually help predict whether, and then the smooth muscle and so forth, if we can find a signal that says, yeah, you're a good candidate for thermoplasty or not, but wow, you're an amazing candidate for anti-IL-5 therapy. And the thing is, what's often overlooked is, a simple bronchoscopy with airway biopsies and lavage is a 5-minute procedure, literally. Yes, it's invasive and so forth, but in the grand scheme of invasiveness, not so much. And if that's the solution, sure, I would love to have a blood test or look at a CAT scan and say you're perfect, but I think that's a while from now. And if that's what it will take to figure out who's our winner here, then I would be glad to do it, right? We're trying to look at, is it actin content? Is it, let's go to the final slide just so I can, there we go. I'll leave the Stanley Cup up, it's better. Plus that's my daughter. I'm like you, I want to know, which direction to go. Because you're right, I can envision a scenario where I do all the paperwork and I start you on omalizumab. I don't get anything. All right, I switch you over to IL-5. Oh, I don't get anything. I do thermoplasty. Oh, good Lord, the paperwork alone involved is going to make all of us pull our hair out, right? I mean, this isn't just write a script and go. We all know it's the eternal frustrating experience. I think that now I'll be the optimist here, though. With all of the biologics coming down, what I think is going to be very exciting, at least, is that for this population of severe asthmatics, where we've had little to offer them, now we have a lot to offer them, and where whatever little we had to fight tooth and nail to get. At some point, it's going to be easier to get because there's going to be. The insurance company can't hold back the 9 therapies that we're wanting to have. There's more things coming down. Something's going to have to give. At least I'm optimistically thinking that we'll just break them. Actually, it's funny. I used to write this long appeal letter about why this person needed thermoplasty, what was good about it. Here's the data. Here's this patient. Here's what's wrong with this patient. And I realized nobody was ever reading it anyway. So now it's down. It's literally a paragraph and a half, and it just says, I am wanting to initiate an FDA-approved procedure that's part of several guidelines now, thereby no longer making it investigational experimental by your own definition, because it's now on international guidelines. This patient has failed the following medications and has suffered the following complications from chronic oral prednisone, which is why I want to use this procedure. New paragraph. If you will not approve this, please kindly offer your medical advice as to what therapy I should initiate to manage this patient who's being killed by their asthma.
That's awesome.
And I mean, I know underneath it, there's a picture. You can mentally see the picture of me with both my fingers sticking up, but it's been working because the truth is, what do you want me to do? I'm a big fan of inhaled steroids and LABAs and leukotrienes and immunotherapy, and if I can take a pill, an inhaler, or a simple injection, and you're a winner, good, right? I mean, I do bronch for a living, but it's not like I want to bronch you. But if that's not working, then I want to bronch you big time. And, let's get going on this. So that letter's been working because it's short and sweet and it's borderline rude. But the truth is, what do they want me to do? I mean, what do you expect from me? Chronic prednisone? That's not a solution. So anyway. Yeah.
Do you have a salvage arm in the people that didn't get better to see if you can follow them with multiple thermoplasties and see if does your protocol allow for that?
We don't have it, no. And like I said, the problem ultimately is I won't be able to get them reapproved for thermoplasty. Now, I will say so far, so we've had 3 people that have not responded, like, clinical failure. And 1, pathologically, we saw them, no touch to the smooth muscle. 2 out of those 3 also had multiple other comorbid conditions. So they were thermoplasty candidates, but they weren't pure. One of them had really severe bronchomalacia. In fact, actually, we were secretly hoping that some of the fibrotic sub-basement changes maybe would stiffen up the airways a little. Turns out no. But, the person like that, always the complicating factor was, well, what was really driving all their symptomatology? Was it asthma or was it true bronchomalacia? This was not, this is not one of these expiratory dynamic airway collapses. This was true malacia. But all through the airway, so it wasn't even someone you could send for tracheoplasty. So it didn't work on her, but I never knew what was driving her symptoms anyway. So I do know that when we look at our own internal data, we're having about a 90% response rate. But that's because I think we're also very selective. Meaning, I had a guy said to me, he goes, I'm here for thermoplasty, I've got severe asthma, I can't breathe, I'm on all these inhalers, blah, 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 blah. And I must have been the only person who asked him, were you a full-term birth? He wasn't. It was a 28-week preemie. In the pre-surfactant, pre-steroids era. This guy doesn't have asthma, he's got bronchopulmonary dysplasia. And no one believed me, so we took him to airway biopsy. Sure enough, no EOs, almost no smooth muscle, classic BPD. And I said, well, I don't know what thermoplasty does for bronchopulmonary dysplasia, but I don't plan on being the guy that finds out. So, I'm sorry you have bad lung disease, but that's because you have the lungs of a 28-week-old. That's when your lungs stop growing. And now that you're 32, you're actually in decline, losing lung, but you started with this size of a bank account instead of this size. I actually said, I sent him off for a transplant evaluation. The first clue was he comes in wearing oxygen. An asthmatic on oxygen should be the first warning sign, right? So, anyway, it was just one of those, we're very much like, hey, this guy needs thermoplasty. Maybe not. I love doing this procedure, but I want to do it on the right people. And so I think that's been our kind of, judicious use of it. So, and that's why I think we have a higher, response rate in our own patient population because we're pretty selective. Thanks, everybody. Appreciate it.
I don't have all the data. So probably go back to
I don't know.
They know why. But now you can get McDonald's all day breakfast, right?
So I don't think all right. Thank you anyway. Lighting it once a week is enough for me. Twice a week. I like breakfast.
Songs, donuts.
Yeah.
You want to chat?
Oh, yeah. Yeah, if you have a minute.
Yeah, give me.
See if I can steal one.
Okay, sure.
Ring it.
So
anyway, Matt, I'll just send her to you. But I just wondered if there's something else going on with her. She switched off everything.
Yeah, to have no C4.
Well, she's got C4. She has a level of 17, which normal is 18, but she's got no IgA. Well, she's got